All right, I'll give everyone one more minute to get your bio break, get a cup of coffee, and then we'll jump right into our next panel. Awesome, the pictures are up. Hello, Greg. Hello, Joe.
Good morning, Josh.
Good morning. If Sam and Jennifer can hear me, if you could throw on your camera too.
I thought I did turn on my camera. This is Jen.
I see you, Jen.
Oh, there I am. Okay, great. Good morning.
Good morning. Give everyone 30 more seconds as they're running back from their kitchen or bathroom, what have you. Or just digesting all of the great conversation that we just heard.
Seriously, so much great, thinking and observations.
Absolutely. I don't see Sam's camera on, but that might just be my perspective here. Sam, are you there?
I thought I was looking through who was attending. It's a good number of people on this panel and summit. I thought I saw Sam's name in the participant section, so you might be needed to be moved over to the panelist section.
Yeah, so I'll give the behind the scenes folks a minute to see if they can try to switch on his camera. If not, we'll be sure to give him, we'll let Sam introduce himself last when we go through everyone. So let's go ahead and get started. This is our second panel on perspectives on the value of innovation. I'm super excited to be a part of this. In some ways, I feel like the outsider here. I'm an innovation economist. I work at Harvard Business School. I teach MBA students. And what I spend my time thinking about is really upstream of a lot of this conversation. I think about how biopharma companies decide where to spend their money in R&D. So the early stages of drug development, how do we decide to get involved in a project? What areas are going to get attention? But as all of the panelists on this panel certainly know much better than I do, you get what you pay for. So we have to make sure when we're having any discussion about R&D, like I do all the time in my research, but also when we talk about valuing innovation, that we have what we think are the right definitions and the right measurement of innovation. So a lot of my interest comes from that perspective of, do we have the right things to look at, or are we getting a bad version of what's called the street lamp effect, where we're shining lights in some areas really well, and therefore you get folks exploring in those areas and we're rewarding innovation in those particular areas, but really we're in the dark for a lot of other elements of innovation that we might care quite a bit about. So that's kind of where I'm coming from on this panel. That's how I think about the problems downstream in drug development and what payers pay for, what patients perceive, and what clinicians are able to prescribe. So all the panelists, oh, there's Sam. We're all here now just in time.
Yeah, sorry, I was in there as an attendee instead of a host, so
we're all attendees and hosts today. Everyone's perspective is valued. So all of your bios are on the website, and I'm sure we'll drop the link in the chat again. So I don't want to spend too long introducing all of you, but I'm going to start off by going around clockwise in the circle that I see you in my window. And I'm going to ask you all to introduce yourself very briefly, but also spend about a minute, not too much longer, saying, how do you define innovation where you sit? So in your organization and in your work, what motivates innovation, and how do you measure and reward innovation? That's how I want us to start here, because that's where we're going to dive into more deeply. But let's just start with, where do you sit? How do you define it? and why do you care? So I'm going to go in the circle. So Greg, get us started.
Thanks, Josh, and good morning, all. Excited to be here as part of this panel. I was joking as we were prepping earlier, I'm probably the dumbest guy here. So Josh tried to take that mantle, I think, a little bit earlier, that he added the least amount of value, but I want to make a run for his money. But from our perspective, I'm a pharmacist by training, really come out of the PBM industry. So we are an offshoot of a group called Purchaser Business Group on Health. They've got 40 members that represent some of the largest employers in the world. So you're talking Walmart, Boeing, American Airlines, Microsoft. And those large self-funded employers were not having their needs met in the PBM marketplace. So when we think about innovation from that perspective, it's really around transparency, patient choice, and prescriber choice, I would determine. Right now the PBM industry really focuses on opacity, hiding a lot of things to create profit, excluding a lot of things that they don't like, again, usually from a monetary standpoint. So we work with groups like Mark Cuban Cost Plus Drug Company, Civica Script, and a lot of these new startup organizations that are really focused on bringing transparency and quality to the PBM industry and therefore to our clients and the patients we serve, versus this world where we go to a pharmaceutical manufacturer. I, as a PBM, can extract a ton of money out of them. Therefore, I prefer their product. And because they're giving me so much, I exclude all these other products. So whether a patient wants it or needs it, whether a provider wants to write that prescription for a patient, the PBM is blocking it because from a cost standpoint, they pull all the levers and control all of those rules. So we're really looking at how we bring a completely different product to market, but then value those manufacturer innovations, which I know we're going to talk about, in a way where we can validate the costs that they should be paying and what that member should also be charged for all of those drugs downstream.
Excellent. Excellent. Let's go to Joe next. Where do you sit?
So my name is Joe Hans. I'm also a pharmacist by background and training. I sit from the payer perspective. So I've spent almost 25 years at several national payers here in the U.S., Anthem, Aetna, Humana, Health Net here in the Northeast. I was liberated from the payer environment a little while ago, so I've begun my recovery process. So I'm a recovering payer, I should say, to the audience. From my perspective, when we think of innovation in a payer's world, it's a bit more incremental. And I suspect it'll be a bit more underwhelming to this audience in that we have a very short-term view, typically, around sort of financial planning. It's a 12-month process. We set the price for our products in January, and we've got to live with that price all the way through the next year, even if something happens like perhaps a pandemic, if you will. And we want to look for innovative approaches that can both include improved outcomes, but ideally lower the cost of care or some form of that care. So we really look at performance and outcomes, quality, and then we're looking at the dollars and cents. We can't get away from that. It's part of our DNA as payers. But we are looking for folks to take new therapeutic approaches, help us deal with the unmet need, reduce the burden on patients, because ultimately, if that happens, we will most likely win as well. So payers are trying to find a way to reduce the price to cover care. And if that happens, people are going to get, hopefully, in a better place. So there is an alignment there, and we're driving that alignment. It may not seem obvious, but it is where we spend time. I was part of an innovation lab at Aetna, and for about 2 years, it was probably one of the best jobs I ever had. We were looking at anything possible that could improve outcomes. We were looking in spaces like autism, and this is about 6 years ago now. The treatment of autism still lacks significant amounts of standards around it. So what is the best evidence? What is the best way to treat autism or help a patient as they kind of progress and grow into adulthood? We were trying to find that because there's a lot of waste, there's a lot of inefficiency, and there's a lot of lack of progression and opportunity. So we're trying to find it. And I think that's the way payers will look consistently at innovation. Unfortunately, we have that 12-month window. And so it kind of inhibits us and prevents us from having a longer term view that most other industries take. So that's it from an innovation perspective. Back to you.
Fantastic. And clear picture of, what is that lens that you're bringing to this discussion. So thank you, Greg and Joe. Next to Jen.
Good morning, everyone. I'm pleased to be here to speak with you all today about this super important set of topics. So I'm with the MITRE Corporation, and MITRE, our motto is solving problems for a safer world. So MITRE operates the federally funded research and development center devoted to health. It's the only FFRDC devoted exclusively to healthcare. We work with all parts of HHS, including CMS, FDA, NIH, ONC, AHRQ. We've been around for about 10 years now. We just celebrated our 10th birthday and learned that we have been renewed to work with CMS and our other federal partners through 2030. So we take a long view of what it's going to take to get where we want to be. And when I think about where we want to be, we've spelled out a framework for thinking about this in a paper that we wrote last fall, and I've dropped it in the chat, but it basically includes a framework for accelerating biomedical innovation that is based first and foremost on the understanding that we need a free-flowing digital infrastructure for the sharing of information across the healthcare system. And I would broaden that even to say, that we're thinking also about how you would share data between the healthcare system, the social care system, the mental health care system. So then once you have that free-flowing exchange of data, which I would note today is the day the information blocking rules go into effect. It's kind of a big day. But once you have that free flow of data, then there are several things that could happen. So the government could have a better modeling capability to sort of have like a dashboard that would allow everyone, all of the different perspectives, to see what's being, what are the implications, the societal value, the long-term implications for all stakeholders of various policy decisions. And we would also then have the real world data that we want to have to make decisions in a learning healthcare system. So I think a lot of our earlier discussion around the potential of real world data and the ability to really understand better what patients need, how to measure those needs, how to value them, and how to balance all of the incentives. I think what we learned with COVID-19 is that we can do a lot of really great things when we all work together, when we're willing to share our data, when we're willing to break down some of the boundaries that protect proprietary interests, not sharing data protocols, IRBs, the list goes on and on. So that's kind of my perspective. Thanks.
So, Jen, because I can't let you get away without pinning you down on the definition. So when you said long-term perspective and you think a lot about data sharing, but when you talk about what is an innovation that you care about, or what will all this data sharing in the ideal world contribute to, what do you mean by innovation? So Joe, it's about saving money and in the next 12 months. Greg, it's about transparency and quality. What is it for you?
So we think that, we're in a democracy. People make choices in a democracy about, the kind of society they want to have, right? We have a system right now that values having very high cost therapies, that values having very few biosimilar therapies, that values, let's call it a vast amount of income inequality. So you know, when you think about our definition of the value of innovation, we're looking at it from a very broad lens in terms of equity and societal value, cost to the federal government and to taxpayers. The federal government, you know, pays now for half of the healthcare for all children in this country and all of the healthcare for everyone over the age of 65. It's an enormous range of spending. And so you think about, well, okay, the first half of, you know, that childhood group, what are we doing to improve health and long-term outcomes in that group? And then for that elderly group, you know, what are we doing to help people age better and age in place? And then in between, we sort of let people out in the, you know, and say, hey, go find a job, get healthcare coverage, good luck. And so we have to figure out how to, you know, how the federal government can help align incentives across that whole spectrum.
Great. Awesome. And Sam, last but not least.
All right, so my name is Sam, and just like Joe and Greg, I'm a pharmacist by training, but for a long time now, I've been more in the research side because I'm a health services researcher and health economist as well. And so I work for UPMC, and I am with the Center for High Value Healthcare within the health plan. And so I come more from the angle of an integrated system. So my team, we are a smaller group within the bigger center where we call it the value-based pharmacy initiatives. What we are charged with is looking at value-based contracts and then trying to find where the value lies. So to us, we look at it more from the clinical side. So most of these drugs are approved with wonderful clinical outputs, and that accounts for the efficacy side of things. And so what we look out for is how does it benefit our members? And so we look at the effectiveness of those medications, and we track most of these outcomes. And then we try to see whether it aligns with what is out there in the clinical setting, in the clinical trials, and to see whether we are paying for value for our members. So more from the system side, we have the benefit of not only looking at the pharmacy costs, we have the ability to look at the medical side as well. And we get a chance to interact a lot with our providers to come up with outcomes that are of benefit to all the stakeholders. So not just the payer, but the providers, and at times we even get inputs also from patients.
So just want to also pin you down. So if I'm hearing this correctly, it's all about the delta in that effectiveness of a treatment. So are you getting better outcomes from that treatment? That would be one measure of innovation. And then what timeline are you thinking about when you talk about outcomes? Are these measured in many years? Are they measured in the lifetime of the patient, or kind of immediate impact of a therapy on a patient's diagnosis?
Yeah, so I would say that it depends a lot on the drug that you are looking at. So there are certain drugs that you could see their impact immediately, like some of these GLP-1s and most of those diabetic medications. You are able to track it within months. Third quarter, you're able to see whether A1Cs are coming down compared to the other products. So some of them you can see immediately. The others also, that would take a while. And so as a payer, most of the times we look at things in the like a year window, and at times we are able to track it over 2 years or more. But there are others also that are based on patient-reported outcomes, where we have quarterly reports where we get to see whether the patients are reporting on better disability indexes or not. And so it depends on the product in question.
Awesome. Well, thank you all for giving us some detail about your perspective from where you sit. It's awesome because we have, even though similar backgrounds amongst many panelists, a wide variety of current perspectives in terms of timelines, in terms of definitions of innovation. So let's jump right in. I'm gonna go back to Greg to get us started, but then any of you can jump in. So the first question I want to really ask is, how well are prices working to reward innovation in the current system? I know it's a big question. You can think more specifically, are we rewarding Me Too drugs, these incremental innovations or copycat innovations too much? Or are we actually okay about, balancing this idea of having more competition within therapeutic classes and having more radical, different kinds of classes, different kinds of drugs coming in? Where do we stand right now? What's your state of the union for our incentives in rewarding drug innovation?
Yeah, no, thanks, Josh. I think it's a mixed bag a little bit. I think some innovation in these new drug categories, even thinking cell and gene therapies, things like that, that are curative for, chronic diseases or very debilitating diseases. Those are products that we fully get behind. We have really talked to, these self-funded employers, and, I think in general, they're scared of these maybe multi-million-dollar price tags coming out. But when they really look at the fact that you go from either dying or being disabled for a lifetime to being able to live a normal, healthy, life, there's clearly a lot of value in that. And they're for small patient populations. But, those drugs make a lot of sense to us. Again, would we rather not pay $2.8 million for some of them? Probably. But, those are things that we can really talk about from a cost value outcome standpoint. Where we do see maybe the innovation not being rewarded appropriately is in some of these biologic categories, maybe HIV, others, where a lot of Me Too products are coming out. We probably have, 12 different competitors to Humira. And I think the manufacturers all kind of figured out, hey, this is a great product. It's a, $28 billion annual category just for a couple of them, and Humira dominates it. So if I bring my product out, here's what I get. So, billions of dollars we spend in innovation, and, maybe coming out with a couple of those products is fine. There's good competition, and then there's just kind of greedy competition. So the other last point that I've got is we think about even competition in some of these areas. The industry of PBMs really lives to drive up price and not drive down price. And again, just picking on Humira as the #1 drug in the world, as more competition came out, AbbVie, the manufacturer, raised the price faster and faster. So it's almost completely counterintuitive that more competition lowers the price, where in the pharmaceutical world, actually more competition raises the price. Because what happens is, as it goes from $3,000 to $4,000 to $7,000 a month that the manufacturer's charging, and there's more competition that the PBMs can pick from on what they decide they want to cover, they go to, say, AbbVie and say, hey, AbbVie, instead of $1,000 in rebates this year, I'll need $2,500 or $3,000 in rebates if you want to stay on my formulary, because if I PBM take you off my formulary, you won't sell any of your product to the tens of millions or hundreds of millions of lives that I cover. So it's really this perverse world where more competition actually drives up price, because the manufacturer has to pay more to the PBM to keep that coverage and accessibility. And if they lose it, they lose all their sales. So that's innovation that we clearly do not align with.
Joe, what do you think about this? How are our incentives doing in getting the right kind of drugs into the clinician's hands and into the patients?
Yeah. So in my recovery process, I've become a consultant, and I work with a lot of manufacturers, pharmaceutical and digital therapeutic manufacturers, to help them price their product. And what I would say is today we price products to the opportunity, not necessarily always to the value, if you will. And I don't know if it's the proper incentive, I think that was the question, to create an environment of hyper innovation. The question you asked, Josh, sort of centered on Me Too products that have different pathways than, say, innovator pathways. And I think if I'm playing my role again as the payer, we see minimal incremental opportunity there from an innovation perspective. If I'll reference something in the opposite direction of Greg, and we'll go in the Wayback Machine. We didn't necessarily need the 8th statin to market back in the day, right? We were getting really good, effective cholesterol reduction, but we got our 8th statin. And at that point in time, it was kind of unnecessary. You know, it wasn't innovation that really moved the dial for just about anybody, other than that company who obviously wants to survive and wants to, be revenue positive and be progressive from that perspective. So I think there is something to be said about, Jen's opening comment around, we saw some, I think, really strong innovation when it came to the rapid development around the vaccines for COVID. People still made money, so we check box on the capitalism, but we also had an alignment within the health ecosystem, right? We had everybody sitting almost on the same side of the table around, let's get this figured out, let's get it out into to the patients, and let's move on. And I hope we all take a breath at some point and really let that sink in, because the timeline from patient 0 to vaccination trial to a large vaccination, large vaccinated population, it's amazing. Warp speed is probably the right name. It might be ludicrous speed if anybody's a Spaceball fan, because it was fast. I mean, we went really, really fast because people
They've
were
gone
aligned.
to plaid, Joe. That's the line.
Yeah, going to plaid, yeah. So I would say that alignment is highly innovative, and people still made money and still continue to make money. I think money is the currency of sort of execution, allows you to keep innovating. But if we all now we're starting to get out post-pandemic and slide back into our environments of capitalism, I fear that the cost of care is just going to continue to escalate, and that really hurts patients from an affordability perspective. So I'm not sure that's where we need to go. We kind of need maybe a guiding light and a beacon that focuses us a bit on, let's go after this, let's go after the moonshot and really drive cancer out of our out of its existence, if you will. That would be great. But I just don't know if money really does that. I think it's societal uptake and societal benefit. Yeah. People living longer. I mean, I would rather live longer than be a millionaire, I guess. I don't know.
I want Jen to build on that in a second, but I'm going to go out of order for a second, which I was hoping to do. To Sam, because you were kind of the opposite perspective. Like, you're all about trying to get the value-based measurements of drugs. So how do you think about competition here? How often is competition actually reducing the price? Or do you see this paradox that Greg was talking about, where more competition sometimes just leads to kind of the behavior we're hoping to avoid of jacking the price on old therapies?
Yeah, so we know that there are certain innovative products that when they come out, everybody tips their hat out and say, wow, this is a great product. So we have, when these Hep C products came out as oral treatments, everybody jumped on board, and it was easy to agree that these drugs are very innovative. At the same time, too, we know that when it comes to this Me Too products and some of those biosimilars, from the economic standpoint, the more of such products that you have, the better the competition, and so the prices should come down. And Greg rightly said that the market failure in the healthcare system is well known. So these things are not happening. Yes, still as payers, it still gives us options, and so we control so many things using our formularies. So of course, if I have 2 or 3 or 4 different products that will do about the same thing, it still gives me that leverage. And as I negotiate with manufacturers, because they know that those other products could easily be given better placement in the tier system. And so that helps to create some form of incentive to move the pricing side as well. And so from where we sit, having more is better, but at the same time too, we know that that's also affect the dollars going into certain areas where you think that should be where the innovation should go. But I mean, recognizing that most pharma companies look at it from both sides, we have to still keep the dollars flowing to have our companies still viable. So whilst we are chasing some of these innovative products that do not come every year, once in a while you have a blockbuster drug coming on the market. And that's the goal of almost every pharma manufacturer, to come out with something like that. But in the meantime, if you're not hitting it or you're missing the mark, some of these Me Too drugs, they fall on it to keep them afloat with the hope that will come out with something very innovative. And so I know that's not the best way to go, but from the business side, I understand why some manufacturers look at, because the Hep C drugs came in and we have several of them, right? Because they're all going for the same dollar. And so hopefully, once we have more than one, we have like 10 different ones, you're expecting that should drive the cost down, but unfortunately it doesn't happen that way.
One of the things I took away from our pre-meeting when I was listening to all the panelists tell me about their work was this idea that, you know, we often pick examples that are curative therapies or are pure Me Too therapies, but the reality is we're living in the gray zone a lot of the time, and that the manufacturer might think that this one small tweak on an existing structure might lead to much better results, but we don't know until years later. Yes. And it takes doing this hard work of, you know, health effectiveness studies, cost effectiveness studies to figure out where we really land. And dealing in that gray area is tricky because getting the balance of competition and novelty is just, yeah, anyone's best guess when you're in that place. Ex ante, always ex post, you can say, did we get it right or not? Did we have far too many statins? So Jen, I made you wait on this, but you have kind of the macro view here. So how do you think about our balance of incentives here?
So it's a really great question. And I wanted to kind of pick up on the point that Joe made about the COVID vaccines, you know, going from a newly discovered virus to a vaccine in, you know, such a short period of time. I think that was an amazing collaboration and a lot of credit to the NIH and to the NIAID, who, you know, they, you know, immediately took it on themselves to design a protocol, go to companies, say, here's what we need. We need a vaccine. It needs to be able to do these things. This is the timeline. We'll pay for the manufacturing. The government took a lot of the financial risk too. Now the companies did take some financial risk as well. I think what you saw in the diagnostic category with COVID was much different. So I supported the RADx program, which was to design and get approved diagnostic tests for COVID-19. And I think what we found there was that there were a lot of companies that came to the table with ideas that were sort of not quite ready for prime time. And the companies were sufficiently small and you know, unexperienced in terms of how to actually bring a product through the regulatory process. Mm-hmm. So I sat on calls 3 times a week for a year and a half with NIH, FDA, going through a list of all of the applications, and there were hundreds of them. And you know, it was, you know, we were having to go through, you know, a spreadsheet, you know, item by item by item. Where is this one? Where is that one? Do these guys know what they're doing? So I think that we have a lot of room to narrow our focus in terms of, you know, getting the investments steered towards the things where we really have a societal need and we have the ability to create value that will help more than, you know, one person who happens to, you know, be the owner of the company who can go out and buy Twitter for $44 billion, right? So the other thing I would say about the you know, issues for the patient community is I do think that the you know, the patient community is not at all homogenous. But I think that, you know, it can be really difficult and frustrating for policymakers when they hear from every different patient group about, you know, every different issue. If you look at the way that the NIH is actually structured, right? each of the 27 institutes and centers has its own line item in the appropriations categories. And then the office of the director has his little line. And it's, it's very difficult to get 27 different organizations to move in one direction. And to prioritize where do we need to make those investments. So that's one of the things we're excited about with ARPA-H.
Fantastic. So the switch modes a little bit from the state of the union, so to speak, and I guess Jen was getting us there thinking about ARPA-H and sort of what comes next. But let's get very specific about some ideas that all of you have, because you think about these issues all the time. So do we need different metrics? And which ones do we have right now? Are you saying, no, they're really functioning super well and let's not mess with that? And which ones would you really like us to see adopt a little bit more? Going back to the metaphor from the beginning, if you could have a street lamp on one area of measurements that we don't have today because it's dark in that space now, what would be most helpful, both for where you sit currently in your job, but also, for the broader picture that Jen has been representing as well? So any of you can take that first.
Yep. Josh, that was to Greg, right?
Well, to any of you, but Greg, get going.
Oh, sorry. It like blanked out for a second. So, I think the interesting thing is we think about it, and Sam brought up the hepatitis C category, and I think that's another one. And sorry to go back to these curative ones, but I think it just kind of sheds light on this in a unique way. 2015, these first drugs started coming out at about a $80,000, $90,000 price point, a little bit higher. You had to take the medication for 12 weeks. So even when we think, adherence, patience, those types of things, that's what we had. Kind of then more of these products started coming out. And interestingly, and I feel bad for AbbVie, so then AbbVie comes out with their product, which is curative in 8 weeks, and it costs a third as much as these other products. So, people should really be celebrating what AbbVie's doing. They should own this market, and yet most PBMs, I will say, most PBMs don't cover AbbVie's product because it's the lowest cost one. And, as we've really talked a lot about that patient experience and what patients need and what patients are then getting from healthcare, to us, that turns into a secondary problem because more plans are using high deductible coinsurance health plans. So then from that patient standpoint, when the PBM is picking the highest cost drugs and having to pass some of that down to the patients, that turns into affordability problems, which automatically leads to adherence problems and therefore poor outcomes. So as we really think about it, it is, how do we say there's a certain value of this class? Here's what the value of this class is, and let's make sure that the people who are creating the rules that drive utilization are doing it in a way where it's not just based on their shareholders' interests, but based on kind of that societal benefit.
Right. So Greg, I want to make sure I'm hearing you right, that the kind of things that aren't getting into that formula right now, and by formula, I mean how much we pay, comes down for you to the patient experience and ability to adhere to the treatment plan. And you think that those are two examples, at least, of uncaptured metrics from the perspective of what gets in the formulary. Is that right?
Exactly. Yes.
Okay. All right, that's great. That's two. We talked a lot about that in the last panel of including the patient perspective and what it's like to actually take the drug and whether or not you complete the course of treatment. Seems like two good ones to add. What else are we missing or just doing quite well in the current form?
So, I mean, I look at it and I would say that we've already established that RCTs are a great way to go. So we have all this clinical data to help us. But then what at times is missing is the cost of the medications themselves, right? Most of these innovative products come out and they are very expensive. How do we tell whether we are paying for value when they come out? Because at times it takes a while for you to see what the value is in the real world.
They talked about that in the last panel. It'd be great to have real world outcomes, but sometimes that just takes too long. So what creative tools if you could wave your magic wand, Sam, which tools would you like to have in your arsenal to get at those outcomes sooner?
Yes, I mean, I know that here in the US, we don't value too much the economic input, right? We focus a lot more on the clinical side. So if you look at what NICE is doing for NHS in the UK, at least there's some form of bringing in some value in terms of the cost effectiveness of the drug. How is it going to impact you in terms of budget impact and all those models that we have there? And so you could see that even before the drug is approved by NIH for NHS for their members to use, they get an input from NICE and it's accepted. So they have a form of telling you that this drug is valuable, although we know there's a lot of controversies that goes on, and pharma or manufacturers have been going back and forth in terms of their evaluation. But we don't have that system per se here. Or no, I know we have companies like ISAR that are trying to jump into the middle and somehow let us know whether we are paying for value, you know, at the initial stages. And we are not there yet, but if we should get to that point where even before we jump in as payers to bring some of those drugs onto the formulary, we have a sense of how valuable these drugs are, because most of the times we depend a lot more on the clinical side, which is great, but then to take a while for us to collect the real world evidence. And if the drugs are valued as curative and it takes us maybe 5 years down the road to realize that it is not as it was, we must have pumping a lot more. And that's where I stand when it comes to some of those issues.
So Greg wants more input from the patient experience and adherence. Sam wants ongoing ruthless cost benefit analysis to make sure that we are paying for real utility in the economic sense. I know that's a caricature of what you're saying, but it's helpful for debate. Jen, Joe, other thoughts here on what metrics we could wave our magic wand and put into these discussions immediately?
Yeah.
Yeah, Jeff.
Oh, sorry. I think that the key here is that there can't just be one. So what has happened, you know, I worked on a paper for the National Pharmaceutical Council in 2009 that I dug up the other day, and we were talking about at that point how comparative effectiveness research was going to, you know, change the world in terms of innovation. You know, in theory, we have multiple organizations with multiple, you know, perspectives using different measures and developing that evidence, you know, ICER, Blue Cross Blue Shield, tech evaluation, the work that IVI is doing. All of that work is incredibly important. Manufacturers also do a lot of that kind of research themselves. I think the challenge, though, is that when everyone's using their own data and they don't want to make their data public and they don't want to make their analytic, you know, assumptions public, then it's really hard to have a balanced conversation like we're having right now on, you know, on what is important and what we really, you know, believe in terms of the analytics, and just because a voice is the loudest doesn't necessarily mean that it's the right one.
Jen, how do we, so let's say everyone makes their methods available tomorrow, and you can sort of check their math of where they get to this final number for a drug. How do we compare across frameworks? You know, Greg wants to think a lot about how the patient's experience, you know, whether I have to go in 12 times or 8 times. Sam wants to think about, you know, is this leading to clinical outcomes I can measure in claims data, et cetera. Yeah, Joe's thinking about the next 12 months for his payer clients. How do we balance all that? Like, it's great, we're gonna have all these people come in a room. Is there a framework that you can bring to this to say, these are metrics that we're undervaluing, these are ones that we're sort of overvaluing because they're there?
I mean, we think there is. We think there is a framework for thinking about this, and we think that there are sort of, you know, in addition to this digital ecosystem infrastructure, that I was talking about before, we think that you do need to have multiple measures, that you need to have this sort of more public dashboarding and modeling kinds of capabilities. We also think the federal government, though, has things that it can do. We believe that that CMS can pull innovation in targeted areas, if the policies are set up the right way. We also believe that there could be better alignment across different parts of the innovation ecosystem within the government, NIH, FDA, CMS. We believe there are opportunities for better alignment there. I think we saw some of that in COVID. How do we replicate? How do we scale that? And then finally, we do think that there are opportunities under current law that the government could do more to invest private capital and attract private into these social innovation bonds or social impact investing funds. And I'm by no means an expert on any of the sort of more the financial part of that. Would love to chat with Walter and Mark about that later. But it's I think the other key, though, is you really have to have the data in a place where everyone can see it. And so another thing we're talking about is, how is it that we have this enormous diverse country, and we don't have a data set that will give you the ability to look at the entire population at the level of granularity that we want. So we're talking to Finland. And we're talking to Norway, and we're talking to the UK, and we're saying, we're talking to, countries in Africa, and like, what do we have to do to get to that data?
That's great. And I love your point on the methods of investing. There are different forms of private capital. We should have a whole nother panel on that question about how the form of capital and the way in which it's invested affects the kinds of drugs that come out of this giant machine. Any more thoughts on, as you've listened to each other, on which measures you just really want to have that we don't have today? If you had to pick one, are there any that we haven't mentioned?
I don't know if I want more. I want everything that Jen, Greg, and Sam said, but then I actually want more than that, because I think of I think nationally or societally, like, how have we leveraged the collective capabilities, skill sets, and knowledges across the continuum to improve the health of everybody that lives here? And I think, believe it or not, that's kind of how a payer thinks, right? They have this large subset of people who are paying them premiums to cover them with insurance. But we think of them as everybody, like the population under my roof. Mm-hmm. And I'm not sure we as a society are getting everything we can out of everybody who's in the health ecosystem, because there are potentially divergent motivations, but there's probably more inefficiencies and waste than anything. So if I was to ask for the magic, you asked, we have a magic wand. So I want to measure our waste, and then I want to improve it 10% every year until we're perfectly efficient. Because, and I see I've blown up the chat a little bit with my statin comment, and I apologize if I did not mean to any indiscretions on the statins, but maybe one of those statin companies could have pivoted toward the PCSK9s and earlier, right? If they weren't as incented to go after another. Oh boy, here we go. Someone
responded that they did.
Yeah, let's just talk in context. I'd like folks to keep expanding their capabilities and resources in a way that goes after bigger, better targets of health outcomes. And if we do that, we are going to invariably increase the life expectancy of everybody on this country, but hopefully on this planet. So the rising tide measure, I'll call it. The tide has to keep going up with how we use our collective knowledge in health. And I just think it's highly inefficient.
I mean, you say rising tide, I think about it as squeezing efficiencies, is that if the market, and often public markets do think this way, care mostly about the efficiency and productivity of those investments, the idea being that you'd force more capital reallocation rather than sort of focusing on a few bright line clinical outcomes that you know are a little sexier. So
I think forcing and pushing somebody to do something is very problematic, especially in this country.
Yeah.
But if you create those incentives of reward and structure it, I think people will run there, not walk.
I'm going to encourage folks to keep asking questions along these lines in the Q&A and in the chat if they want. But I'm going to ask one final question of our group today. So we've mostly been talking about what I would call direct value. And direct value meaning, you know, how could we better spend money today, or how could we get better clinical outcomes today with the drugs that are available? But a lot of my job is to think about these dynamic efficiencies. So to think about what's happening in the future. And, you know, of course, we want to measure what is valuable in drugs today, but you also want to signal to this whole world of R&D that you will get rewarded for doing something new and different, or that opens the door, even if it's not successful itself, but opens the door for follow-on efforts. And we talked about the statins. There's some great examples there where some of the earliest statins actually weren't so commercially successful. And, you know, the ones that outpaced them came a little bit later. And we want to make sure we incentivize that kind of door opening activity. So what do you think we could do from where you sit in your organization or as a society as a whole to encourage that sort of building block cumulative innovation?
If I can jump in here, I'll look at it and I'll say, we are already incentivizing certain drugs that are high cost, right? So if you go into the real orphan drugs is an example. All those cancer drugs are example, and we see a lot of activity going on in that arena. Some will argue that certain areas that could still be useful, like if you look at the antibacterial area, it's a long time we found something real innovative coming out of that area, because there's no incentive. How much money will farmer make if they go in and come out with something that's, you take it for maybe 3 days and you are cured and it's gone, right? So although the incentives are there, but I think they are tilted more towards where manufacturers will make the most, and not necessarily putting everything into consideration what society will benefit from. I mean, vaccines are a different example altogether, but those small areas where the incentives rewards might not be that great, it's hard to assume that investors will go that route. They will often go for where they will have the most for their buck.
Other thoughts on this one? I have a few questions from the chat I can go to, but I don't want to jump ahead too quickly.
Well, I did have one thought on your question about, you know, sort of how do we create the roadmap to where we want to be, and I think that, you know, one thing that we're looking at is this issue of, you know, we have a lot of fragmentation in our public healthcare system in terms of the way that healthcare is being paid for and delivered. So, you know, that results in differential outcomes. It results in differential, you know, results for different populations. We know we have huge inequality and equity problems. So we've done work recently on what's called the 3Ms, or, you know, Medicare, Medicaid, and the marketplaces. And, you know, how do you make more seamless transitions from one to the other? You know, another area that I think is, you know, a potential, you know, place for innovation is in looking at Medicare Part B and Medicare Part D, and you know, sort of, you know, what are the incentives for, you know, the point of care in terms of, you know, what to choose. I think we have a long way to go in terms of getting to a point where, you know, providers and patients have a shared understanding of the different outcomes and the cost impact, and can understand whether the differential out of pocket for the patient is, something that they can afford and that is worth their paying. So I think we have a long way to go just in terms of that shared decision making. But I think that, again, it's all about the data.
For sure. So I want to make sure I get some of these in from the chat. Combining a few of the questions, a bunch of folks are really asking, how do we get measures of value that include the patient perspective? And Greg has talked about that a little bit. Joe has talked about that a little bit. Sam has talked about including that, but making sure that we can, actually measure what it means to have a valuable outcome. What do we think about it? What are we missing here? How do we bring that into this without it being sort of, again, characterizing it maybe ungenerously, but like the fluffy qualitative side? How do you bring that into these sort of hard numbers, data-driven decisions that Jen is imploring us to show?
So, yeah, I mean, I saw the question in there and I started to type out a response, and it's hard to be thoughtful and present at the same time. But I think there are components that, ICER does some quality work. I think there's patient-reported outcomes that are valuable. I personally would love to see and think it will happen is that there's an ability for us to maybe have a more passive measurement around someone's life. So, for instance, I think rheumatoid arthritis was a conversation in the previous panel, but arthritis in general might, prevent you from being active, right? Your joint pain, you might have a more sedentary lifestyle. Perhaps we could track your activity and with the patient's agreement that let's see if you're on a medication and if you're more active, passively, hopefully that means your life is better. You're able to go do stuff on your own or get out of the house and have a full and enriched life. But if you're on a medication and you're actually sitting around even more, well, maybe that's the time to start looking at, is that therapy or something else impeding your life? So I often would talk about let's pay for what works, but let's also stop paying for what doesn't. And I think this ability for us to see someone's life without them having to tell me constantly, I've got a happy face today versus a sad face versus, some sort of radar in the house knows that I moved around a lot more today than yesterday, or my phone tracks my movement and my orientation. Again, everybody's got to agree to this, but I think there's a way for us to get to a more seamless, easier measurement than we've got to do a randomized trial. We've got to do a pragmatic real world evidence trial. All this stuff costs tons of money. We all have this thing. I bet everyone on this panel could grab their phone in a moment's second and show you that they have it. A lot of people wear a watch. I think there's just ways for us to get into data collection and assessment that is technologically advanced, like who we are, right? So that's where I'd like us to go. I think the data science work is just starting. I'm really excited for the next 10 years. We've got a ton of people in that space. When I started at Aetna, we had 20. By the time I left, we had 200. So it's coming and it's going to be amazing. So that's where I'd want to go from a patient perspective.
Just to comment a little bit on the patient perspective, in our side, we've been able to incorporate most of those ones in our measures, especially at times when we agree on some of these value-based contracts. We do DAFI surveys where we involve stakeholders, including patients, to ask them which of those measures are of importance to them. And at times it could be being able to walk instead of not ending up in the hospital. And at times it's absenteeism, making sure that I'm able to work. So we've incorporated some of those in some of our measures, and we collect data, and then we use it to go back to manufacturers to tell them whether the products are working or not. So although it's a smaller area, but once we report most of these, we can get a lot more payers to collect some of this data, which when we put them together can become a resource for others as well.
Greg and Jen, any thoughts on this? Great answers from Joe and Sam both. Thank you.
Yeah, I don't think I've got anything a major substance ad, I think as we continue to think about it, what goes through my head is how we just make the process easier and more affordable to patients, because the sad reality is we've kind of been talking about here this morning and early afternoon, I guess now, we've got great curative drugs. I mean, nobody should die from diabetes or heart disease or, hypertension or any of those things. And yet, as we sit here today, bad outcomes continue to occur. And it's not because we don't have really good innovation and great pharmaceutical products available. It's because for various reasons, patients are not taking their drugs. And so for us to kind of fully understand, maybe it's not just about the drug, but how's the system negatively impacting patients, as we've talked about? Where's the support needed to make sure that they get on those drugs? And then how do we put value into these other areas to really say it's not just the cost of the drug, it's the outcome we care about, and tying those two things a little bit closer together.
Jen, any closing thoughts on this?
As I think about it, where we're going in terms of data-driven decision-making is, that we have tons of data now. What we don't have is the insights that we need, sort of at a societal level to make the decisions, that would be beneficial. And I think you see that in, the different ways, for example, that, that states are approaching their Medicaid and their marketplace programs, the different ways that states are looking at reproductive health now. We have a very complicated system, and I think that the more sort of unified measurement frameworks and data collection that we have, the easier we would make it with the right analytics and them being publicly available. I think that we would have, opportunities for a lot of better decision-making at a lot of, levels in society.
Great. Well, thank you all for sharing your different perspectives and ideas for how we can do better. I'll throw one controversial one in the mix just so before you get your lunch, which is death to the self-reported Likert scale. So hopefully this gets out of your question. McKay, I thought Joe and Sam had great thoughts on this too. Let's measure what we care about. So if you're an economist like me, what you think about is productivity, health utility, all of these things combined, because all of them lead to general welfare. So there's no reason that we need to prioritize one over the other. Just start with what are the things we care about in the population, and then just go measure those things rather than asking people to do 1 to 10 with a smiley face. I had hip surgery 2 years ago, and I filled out more of those than I can ever thought I would dream of. And it's not that useful. We all know that. And it's great that we're producing drugs that start to move in direction of cures. It would be even better if we produce drugs that that actually reward the measures we care about instead of those Likert scales. So that's my parting thoughts. Thank you all for sharing your perspectives, and we'll be back, I guess, at 12:40 for our next panel on how HTA methods align on perspectives on innovation.
Great.
All right, thank you.
Thank you all.
Awesome. Thank you.
Thank you, Josh, and thank you to all of our morning session speakers.